This is Dr. Sarkissian. This video demonstrates our basic safety protocols for removing mercury amalgam fillings, sometimes also called silver fillings. I have to remind the viewers that we never talk patients into replacing their fillings unless there is reason to, such as evidence of tooth fractures, decay, or leakage. Replacing mercury fillings does not guarantee any improvement in general health, other than the fact that a source of significant release of mercury into the system is being removed. The precautions we take are mainly to protect the patient and the staff from mercury particles and vapor released by the removal process. First, we measure the currents in the metal fillings, also called galvanic currents. Because metals act as batteries inside our mouths, a high negative current means more corrosion of the amalgams, therefore more mercury release. High electric currents are sometimes behind unexplained physiological and neurological symptoms, including headaches, facial neuralgia, and a change in taste perception. If we had a choice, we would remove the amalgams with the highest negative currents first. Before we start, the patient is given a suspension of activated charcoal to drink. This ensures that any trace of amalgam or mercury that may slip through the defenses will be absorbed and bound before it enters the intestines. The first precautionary measure is to place a rubber dam, a sheet of latex-free rubber which isolates the teeth to be worked on from the rest of the mouth. The teeth are inserted through tiny holes placed in the rubber sheet, and this is stretched to allow a clear view of the teeth. Small cracks between the rubber and the exposed teeth will be covered and sealed with liquidam, a paste which is injected into those spaces and cured. The main objective for tightly sealing the rubber dam around the exposed teeth is to prevent particles of amalgam and mercury vapor from entering the mouth cavity. The most harmful form of mercury during conventional drilling is mercury vapor, which is produced in enormous amounts whenever an amalgam filling is agitated or heated. This is perfectly demonstrated in the famous smoking tooth video made by the IAOMT, which one can see also on my website. To purify the air around the patient, the large hose of the dentaire vac, a powerful air filter, will suck up contaminated air and will filter out mercury vapor by passing it through a layer of activated charcoal. The patient's nose and eyes are also covered with a moist napkin. Mercury vapor is highly soluble in water, therefore it will be trapped in the napkin. The drilling process generates a cloud of mist that spreads throughout the room and settles on hair and clothing. For that reason, the protective coverings and air filter should be basic protocol for any dentist removing mercury. Since grinding releases mercury vapor, we try to minimize this by using an abundant water spray and a slower electric drill, which has an RPM of up to 40,000 instead of the usual 400,000, as is the case with conventional turbine drills. After the mercury filling is removed, the underlying decay is gently excavated with an even slower drill, or sometimes with a laser. One important measure which minimizes mercury vapor production during drilling is the chunk removal technique. Following are some examples of amalgams which are removed with this technique, which involves cutting trenches through specific points across the amalgam fillings. The fragments are then dislodged with an instrument. Since amalgam is not bonded, the fragments sometimes just pop out during the drilling process. After the amalgam is removed, we face our next challenge, which is the underlying damage. There's almost always extensive decay, cracks, and weakening of the walls of the tooth, as some of these examples demonstrate. In Ara's case, all the teeth revealed decay under the removed amalgams, but all were filled directly with bonded composites. This last example shows another case with extensive decay, which could not be restored with a simple, white, direct filling. After the decay was removed, a significant part of the tooth structure was missing. The floor of the cavity was bonded and insulated with a core of composite. The tooth was shaped, and an impression was taken for a porcelain onlay. This was made in a lab and bonded in place 2 weeks later. An onlay is a very durable, biocompatible, and cosmetically beautiful option. Because the healthy part of the tooth is preserved, it is more conservative than a crown, but at the same time it reinforces the weakened parts of the tooth in a way that mimics nature. Hence the term biomimetic dentistry.